This conference will now be recorded.
Sorry, we were having some internet issues, so it took everybody a little bit up here.
All right. So there was a question or two questions on the test that the majority of the class missed. And I can tell you why you missed it.
I still got 2 questions left, just so you know.
Huh?
I still got 2 questions left because the whole freaking big problem with the internet.
Yeah, it's cool.
So you gotta give them a minute, it could be one of the two.
Yeah, it might be. So the first question, I'm sure that everybody has a question about, was the one about the patient with a GI bleed.
Yeah.
So where y'all mix that up is how many people put that it was hypovolemic shock? How many people put that it was compensated shock? So, one, it didn't ask the type of shock. The type of shock would be hypovolemic. The stage of shock is either compensated or decompensated, right? And because she was hypotensive, that turns it into a decompensated state of shock. Right? So because she was decompensated, or because she was hypotensive, she is then in a decompensated state. Because when you're in a compensated state of shock, you get the tachycardia and stuff like that because your body's like, what the frick is going on, right? Well, once your body starts becoming hypotensive and shutting down on you, now you're in a decompensated state of shock. So the second question that a majority missed was the question about the 27-year-old that snagged their hand on the piece of equipment or whatever, right? So it says that the bleeding is slow and dark red. What does that mean? Slow and red? Slow and dark
I
red.
don't know what that baby was.
The oxygenated.
Venous?
So a capillary bleed, when you think about like capillary bleeds, or what you're gonna most commonly associate that with, right? Is like when we check a blood sugar, that is like a capillary bleed, right? Because it's like very, very close to the surface. It's just like a very minuscule, somebody gets like a small abrasion, they just kind of have like that bubbling of blood on there. That's like a capillary bleed, right? What's the difference? What does our arterial bleed look like? Bright red, spurting. What does the venous bleed look like? Right? So if you have the dark red kind of oozing blood, that's going to be a venous bleed, right? And I know a lot of people don't know what the cephalic vein is, but it was a venous bleed. So that's where most people miss those 2 questions. Cool?
I have another question.
Oh, those are right.
I have another question.
I was like,
So
I
it's
can't
like-
do that. It's like, I can't do surgery. What can I do? It's my blood pressure.
Really?
So I was thinking like, what can I do? I put high flow oxygen.
Yeah, I failed this.
So we're going to talk about this later.
I don't like that one.
So her question was,
And mostly because it's like, I think
that's the same question
what
she
can
was
I
asking.
do?
So the question is basically when you're dealing with trauma patients, what is your priority, right? A lot of people pick ALS provider.
Yeah, that's right.
I can't do a goddamn thing for a trauma patient. Ask him. The only thing I can do for you is stick a needle in the side of your chest and give you pain meds. I'll be honest with you, me and Becca worked 3 years on an ambulance together as advanced EMTs. We ran 100 gunshots in that time, and those people do zero benefit from a paramedic being on scene. Especially if we don't have access to blood products, we don't have access to any kind of surgical capabilities, right? Because if somebody gets shot right here, what's up here? Okay, can I do anything to stop their liver from bleeding? Trauma patients need surgery. Trauma patient needs a hospital, not this one. Trauma patients need a surgical capable facility, right? So that's our goal with trauma patients. Whether you're an EMT or a paramedic, it doesn't matter. The only thing that I can do that you can't do is pain management, realistically like airway management, but you can use OPAs and BBM. It's very rare that a trauma patient really needs a tube prior to them getting to a hospital. Right? Most of the time you can get away with just doing an OPA and a BBM. And most of these patients are going to need quick surgical intervention. Because you can take somebody that's shot in the liver, right? They carry 8 units of blood over here. So they carry 8 units of blood over here. Becca will talk about how much blood is in the human body today. So they carry 8 units of blood over here. Well, if somebody's shot in the liver and they're bleeding out, that's basically trying to take a cup, drilling a bunch of holes in it, and filling it up with water. You can pour all the water you want to in it, but if you don't plug those holes, it's not going to stop it from spilling out, right? So these people need surgical interventions. That is our #1 goal in trauma, is surgical interventions, quick assessments, and getting them out of here as soon as possible. That's why we bypass this hospital with most of our major traumas and just put them on a helicopter and send them out. So. I like where your fault is, but we just can't do much for them.
The whole closest, most appropriate facility, that's what I contemplate.
I looked at it like.
You can have a hospital that's right here,
Yeah.
but it's the most appropriate.
And the most appropriate is always going to be a surgical facility because, like I said, I can only do like really pain management and like needle decompression. That's probably going to be the closest thing we can do to like saving a trauma patient is the needle decompression. Outside of that, we can't do anything else.
All right, chest and abdominal pump. Super fun stuff. Okay, our objectives today, so we're gonna review A&P. It should all be reviewed because we all took A&P together. Determine injury patterns of the chest and abdomen and how to treat them accordingly. So we're gonna look at different ways to treat. And then review the lethal triad. So we talked about it a little bit. I have like a little picture. We're gonna talk about it at the end of this PowerPoint. Chaz is gonna talk about it in his case review. If you have a good understanding of the lethal triad, you will save more patients than if you don't. So there's certain specific things that we do, and this lethal triad is important into understanding why we do these things. So if you go any further in any kind of healthcare besides EMS, EMT, paramedic, they will drill the lethal. It's not even a triad anymore, it's a diamond, but they will drill it into your skull. So, all right, here's our chest cavity. You can see all the vasculature in this. So there's a lot of veins, arteries in this little tiny area, right? So these, what do you think these follow? The ribs. You think they go above or below the ribs?
Above?
Below the ribs. Yep. So I was always taught the monsters hide under the bed, the veins hide under the ribs. That's how I remember. So collarbones, the diaphragm, here's your chest cavity. So this comes into importance whenever you're looking at injury patterns, because if something's really high up on the abdomen, it could be like diaphragm involvement or lung involvement. So like Chaz likes to point out, if you go like this with your hand and stick it up in your armpit, that's about as long as your lungs are. So kind of puts into perspective how big our lungs are in comparison. We have 12 sets of ribs. Our sternum is where? You all know that from CPR. Then we have our thoracic spine vertebrae. So whenever we're talking about on the backside over here, the vertebrae are in here. They're more stable than our like cervical spine because it has something to hold on to. So our cervical spine can move around a lot more freely, a lot more prone to damage. What's a scapula?
Scapula with your back.
The shoulder blade, right? And then our heart sits right here. That comes important.
It's all right.
Large blood vessels. So what blood vessels would we consider large? What did you say?
Aorta.
Yeah, the aorta, and what else? There's one that runs right next to it. Yeah, the inferior vena cava. And then our lungs. So our lungs supply our respiratory function. How do we, what things do we use to take a breath every day? Diaphragm. Intercostal muscles. All right, so they all work together. And I figured out how to put GIFs. Is that how you say it? GIFs on a PowerPoint. So
It's a joke.
stuff. So I don't know, but it's cool. So inhalation is your active process. To inhale, your diaphragm comes down, your ribs kind of come, take that deep breath, and then to exhale, everything relaxes and that diaphragm comes back up. So it's a negative pressure system. This is important when we're talking about pneumothorax and hemothorax. Because of that negative pressure, if there's any extra pressure that shouldn't be in there, that's where your lungs start collapsing. So here's our abdomen. So this little purple at the top, that's where your diaphragm sits. It kind of just gives you all your little guts a hug. And then in EMS, we divide it into 4 quadrants. So it is important to know which organs are in which quadrant. Because whenever you're looking at injury patterns, if you're talking about pain, any specific bruising, it gives you an insight into what's going on. I tried to make this red line a little bit bigger, so it's hard to see. I apologize. What sits right here and like holds everything right here?
Peritoneal.
So that's the lining, but there's like specifically a bony structure that's like right here. Yep. So that's important too, because any kind of pelvic injuries, our pelvis can hold a lot of blood, right? So hollow organs tend to, I'm going to say tend to, because they're not always, but they tend to tolerate trauma well. They don't bleed as much. They can like puncture and perforate, and that's where it like becomes a problem, because all of those inside juices get out into the peritoneum, where we don't want it. Because what can it cause if it gets out there? Sepsis. Good job. So whenever we're talking about solid organs, the liver is a big one. They bleed a lot. So try to avoid the liver, spleen, pancreas, kidneys is another one. And then what our hollow organs are talking about, like our intestines, our stomach, that kind of stuff. So the physiology of abdominal organs is dependent on individual function. So how is that organ working in the body? So this can come into play whenever you're talking about like geriatric patients or somebody that has like chronic, say like liver problems. It's gonna all act a little bit differently. So the diaphragm, it's dynamic because our diaphragm moves up and down. Our diaphragm also holds everything in. So there is a possibility in like severe trauma where they take that diaphragm actually ruptures and those valves come up into the chest cavity. So that's a bad day for everybody, but it takes a significant amount of force to cause something like that. And then again, the large volume of blood, because look at all of this vasculature. There's a lot in there that pumps a lot of blood. So any kind of nick or sever or injury to that can cause a lot of problems too. So, some problems. Obviously, disruption of breathing is a huge one, right? If they're not breathing well, that's going to be an airway problem, right? So, say somebody has a bullet hole in their chest, and you're doing your assessment. Do you feel like treating that, like doing occlusive dressing or covering it with a gloved hand? Is that part of your airway management?
Yeah.
The answer is yes. Yeah. So that's a life-threatening emergency, right? Hemorrhage and shock, with all that vasculature that sits inside our chest and our abdomen. If they're bleeding out into their belly or into their chest, hemorrhagic shock is always a possibility. And then disruption of organ function. So if that organ gets damaged and there's a disruption there, that can be a problem. Infection, we talked about, if one of those hollow organs bursts or something from the outside gets inside, infection. What is this here? You say cool? Oh, okay. I was like, yeah, it is kind of cool for them.
Add to the wall.
So yeah, this lung is collapsing, but if you look, there's also filling with blood. It is a hemothorax. You could probably consider this a hemopneumothorax because there's blood and air getting in there. So that's kind of what's going on inside the chest cavity. What is that?
Wow.
Evisceration.
That is an evisceration. So I will say, as we're learning to treat things that, like certain injury patterns, whenever we're talking about organs that are normally wet, keep them wet. So moisture gauze, get your gauze nice and moist, put it on there, cover it up. If it's an eyeball, your eyeball is normally wet, keep it wet. So that's kind of the easiest way for me to remember how to treat those kinds of things. All right, so chest injuries, there's a bunch of different kinds. We're talking about blunt trauma. So if someone says they have blunt trauma to the chest, what kind of mechanism of injury are you thinking with that? A bat to the chest?
Or
What is it?
collar. At the
Yeah.
sternum.
Yeah, on the inside of the car, right? Because as Hannah was teaching you guys that there's 3 different collisions that happen in a motor vehicle accident. There's a vehicle hitting something, you hitting something inside of the vehicle, and then all of your organs hitting the inside of yourself. So blunt trauma, this can cause fractures of ribs, sternum, cartilage, that kind of stuff. Bruising, that all goes in here. If we're talking about like a simple rib fracture that's not like your flail chest, that's important, not your flail chest. A simple rib fracture, they're very painful. You'll see like patients with rib fractures, they tend to kind of like hold themselves. They don't take very deep breaths. It's very painful, but most of the time when it comes to something like that, it's not super life-threatening. All right, and then where it says not usually life-threatening. If you're getting to the point where it's lacerating the blood vessels and the lung tissue, that's where you start to have the bleeding inside the chest, the pneumothorax, the contusions on the lung. And that's not always like just a right now problem. So if you think about like somebody with broken ribs and they're not taking good deep breaths and they've been dealing with broken ribs for a little bit, what do you think they might be susceptible to kind of down the line? If they're not opening all those alveoli as they should. Pneumonia, yeah, so they're not opening, they're not recruiting, stuff builds up, gets infected, and it leads to pneumonia. So here's kind of a picture of just the broken ribs. You can see down there, there's like some bruising and stuff.
So what makes it flail chest is just the paradoxal movement?
So the definition of a flail chest is gonna be 2 or more ribs broken in 2 or more places on one side. So what happens, there's a really good picture coming up, but what happens is like a chunk of their ribs is moving freely away from their chest. Whereas something like this, where it's like one fracture down each, those ribs are still like held together. Whereas if you have like a chunk broken out, as you breathe, that's gonna do this number out, start to lacerate and break things. So rib fracture treatment. Back in the day when I first started, my EMT class, they told us to take a sandbag to their chest. Please don't do that. Okay, sandbags are heavy. They're already, like, their breathing's already restricted. Please don't do that.
You just carry sandbags.
So,
No, they used to tell us to.
yeah, when I first started my EMT class, they're like, take a sandbag. And then right after I got out of EMT class, they're like, we don't do that no more.
Yeah.
That's not
What
a
used
thing.
to the sandbag do?
It would
It's
stop
like a
that,
splint.
it would stop that
Just
paradoxical
carry the
movement.
sandbag around.
I guess tactical sandbag.
Yeah.
Sandbag.
They used to teach bulky dressing also, but they're not doing that anymore.
Yeah, so so from what they've done in studies that I've read, is that the bulky dressing can be like more of a comfort thing to them. The problem is you don't want to restrict their breathing anymore. And the best thing for them, if their breathing is messed up in any way, it's actually going to be positive pressure ventilation, because you're providing a splint on the inside because of that. Like we were talking about PEEP and you're providing pressure, it's kind of acting as a splint on the inside. If that makes sense. All right, so obviously we're going to treat hypoxia, treat your ABCs, all that fun stuff. If it is more comfortable for them to hold something up against their chest, we were talking about they like to self-splint. So if you have access to a pillow, that's really comfortable for them, I guess, as comfortable as it's gonna be. It's still gonna be painful. So here's that flow chest that we were talking about. What kind of chest wall movement are you gonna see with the flail chest?
Paradox.
Paradox.
Like
Yep.
the key word in all these so far.
It is, yeah.
Mhm.
So you can see like a chunk of that is broken out. So 2 or more ribs broken in 2 or more places on one side of the chest. Yeah. I told y'all. It's done. See it like moving opposite of their breaths. So that chunk, as they inhale and the rest of their chest comes out, that chunk that's broken is gonna sink back in, and then vice versa. As they exhale, it's gonna come back out.
Kind of looks
So, what's that?
yeah, he said it just looks like an empty hole.
It
Like
does,
there's
yeah.
no way to be above there.
Yeah, and when you feel something like this, like if you're doing your assessment, you're gonna feel like crepitus, moving of bones, and it's icky.
Stop touching
Don't,
it.
yeah, because you think like these ribs are broken with every breath, like you said, what is it tearing up? You know?
You don't think one rib broken in 2 places would do that?
So I've seen recently, actually, I had a guy that had a couple of different like segmented ribs that were broken, and it didn't have the paradoxical movement. So I'm not gonna say that it can't happen, but
Yeah, no.
When I went through school, they taught 3 or more ribs broken in 2 or more places on one side, and that's why it was so easy for me to remember because it was like 3, 2, 1. But y'all's book says 2. I've never been like, how many ribs did they break? If I see that, I'm gonna be like, well, okay. So, yeah. All right, so treatment of your flail chest, ABCs, apparent life threats. When we're talking about apparent life threats on y'all's sheet, what do you think we're talking about? Like, especially in trauma.
Medium bleeding.
Yeah, major bleeding, that's the big one. All right, oxygen administration. These people, if they are alert to talking to you, they are gonna be uncomfortable. So this is not a pleasant thing for anybody. So consider the possibility of the pneumo or the chemothorax or the pneumochemothorax. Do a good assessment of lung sounds. Make sure that you're monitoring their SpO2. And then remember to treat your patient, not your monitor. If they look blue or they look like they're really struggling to breathe, we're still gonna give them oxygen. Do not restrict chest volume. Do not tape a sandbag to the chest.
Pocket sound.
All right, so when we're talking about penetrating chest injuries, what kind of mechanism of injury do you think causes penetrating chest injuries?
Pew pew.
What else? What'd you say? And what else?
Knives.
Knives? Yep. What else? What if they fall on a piece of rebar?
Yeah.
Goes in, right? Yep. All right, so if you can, and you have the capability to determine the object that penetrated their chest, try and get a good description, or I've taken like knives to the hospital with me before, just to show them like, hey, it's a very knife, or oh, it's a steak knife, that's this big, or machete or whatever. Just
Yeah, what's
even steak knife.
Big steak, right?
Yeah, so try and get a picture of it, try and kind of get a good description, so you can kind of get a good idea of what's going on inside. Because a tiny little puncture could have been done by a knife that was pretty long, you know. So these open wounds, they allow air into the chest. This is kind of the best picture I could find for this. So this air comes in and it starts to squish that lung down, right? And what sits right here? The heart, yeah. So that could be a problem.
You done it now.
Okay.
Bleeding.
All right, and then if you see another one, I told y'all, I warned you. And it's gonna be like this from this point on. I love it. All right, so what is this? Let's say this is on the chest.
So
Yeah, sucking chest wound.
big.
That's a big problem, right? If you are cutting off a shirt and you see that, left hand. So I think by definition, to actually cause a sucking chest wound, it has to be like a certain size and diameter in comparison to their trachea, because physics, I don't know. But if you see like bubbling or this or any kind of like lung movement up on under there, that's a problem. So there's that bubbling.
You have to make the noise.
So sometimes it'll make a sound, sometimes it doesn't, sometimes it just causes little bubbles. So we're still gonna treat them the same as any other penetrating trauma to the chest, but they love to ask questions about sucking chest wounds. It's not a good day. So how are we gonna treat a penetrating chest wound? I like that. That was very good. I like your- It was good. So I got from this occlusive dressing on the whole. That's what I got. So yes, we're gonna do that. What is the definition of an occlusive dressing? So when we're talking about occlusive dressing, it's more so the material that the dressing is made out of.
Me and Mike almost went rounds first day of class over this.
It's like, how dare you?
So this is a common use for our occlusive dressings. These are Vaseline gauze. I'll tell Mike the same thing I told, or I'll tell y'all the same thing I told Mike. Do you know what we use these for in the back of the ambulance? Absolutely dick. We tear them open, we throw away the gauze, and we use them as occlusive dressings.
So the occlusive part of the occlusive dressing
Mike uses them all the time.
is the material, air can't get in and out through it. So yes, you do tape it down on 3 sides. That is correct. But you don't have to, because sometimes you can put an occlusive dressing on and tape it down on all 4 sides. That's not like the defining part. Just as long as it is a material that air can't get through. So what we're doing is we're putting this on the outside of their chest, allowing outside air to stay out. But whenever we tape it down on 3 sides, it's allowing that inside air that shouldn't be there to escape.
And you
So it's
can
like a
burp
one-way
these
valve.
too. And so if you see like tension pneumo morphologies and you're not able to do any other interventions, right? Because I know everybody loves the needle decompression thing as a paramedic, but if you have one of these on, you don't need to needle decompress them most of the time. You just open this up and it's
Yeah. So we'll talk about tension pneumos here shortly, but yeah, we do burp them. Even if you did the 3-sided tape, sometimes leaking from whatever, blood, leakiness, sweat, it still forms that seal, so sometimes you gotta open it up and burp it. Where on our chest or the patient's chest, what location of the injury should we be applying an occlusive dressing?
Is it to the worst?
Neck to navel.
Neck to navel, yeah. So up here, why up here?
Because you don't want air going in there.
Yeah, you don't want air coming in here.
That's a
And
makeshift
navel.
stomach.
Why the navel? Belly button seems really low. Why? Yeah, they're a little bit different. You don't know where that diaphragm is sitting. And sometimes what the bullets do whenever they go into the body. Yeah, they never follow the same spot. So, yeah, any penetrating wound from neck to navel, front and back, it's an occlusive dressing, okay? I've had where I put like occlusive dressings kind of lower down and doctors are like, why did you do that? I never know. You know, I don't know. I can't x-ray them. I can't see inside of them. So I'm going to treat it. So we talked about stopping the movement of air and that flutter valve. That's what we're talking about, that one-way valve. Burping it. Here's a good example. So outside air bounces off. Inside air can come out through that little open. You can do just the corner. You can do a whole side. Same kind of idea. This is a manufactured occlusive dressing. So we have one sitting right there. These are pretty cool. Some of the brands, their sticky stuff actually has like a chemical in it that makes it more sticky whenever it comes in contact with blood. So that's beneficial, right? Because what's usually all over their chest if we're putting on an occlusive dressing? Good. So these, because they're manufactured, you don't have to worry about taping them down. They're sticky. And then these are those vents that is gonna allow that flutter valve to let that inside air get out. That's what they look like. You wanna hold it in front of the camera too?
Yeah.
Hype it.
I'm pretty sure they have them down in Austin too, so
Okay.
if Kim wants to show them. But this is what we use most of the time to like take down if we do needle decompressions. I know it's kind of expensive tape, but it works really, really well and it will adhere to a lot of wet material, so it's really good to use.
Yeah, they're nice. All right, so pneumothorax and tension pneumothorax. What is the difference?
Tension is worse.
Yeah.
It's getting really a lot of air in there that's pushing things over.
Yeah, exactly. So tension is worse. It's causing an obstruction of our heart. And so what kind of vital sign, because I can't x-ray into their chest, get their heart squished. What's gonna tell me that they're starting to tension? Yeah, they're trying to compensate. What else?
Rapid heart rate.
Rapid heart rate,
Low blood pressure.
blood pressure goes down. What happens to their neck veins? Yeah, they bulge out. And in really, really late stages, I'm gonna emphasize this because they love to throw it in questions. Tracheal deviation, yep. And most people, unless they're teeny tiny and you can see every structure in their neck, you're not gonna see tracheal deviation, you're actually gonna feel it. So,
I know, I keep getting like test questions that'll have, the deviation goes to the unaffected side.
that's correct.
Yeah.
Yeah, so it
apparently
goes
it's a
to the
big
good
question.
side, because this part's being crushed down, so it's gonna try and create,
Suck up air.
yeah, it's gonna try and create like the path of least resistance. So, diminished or absent lung sounds, signs of shock, tachycardia, hypotension. If the patient is telling you, I can't breathe, that should be a good indicator.
I can't exhale.
Here's that picture of the trachea deviating.
Pretty much.
And like I said, this is a late sign. If they're to this point and you didn't, like if they progressively got to this point in front of you, you missed something. Because like we say, your patients don't suddenly die or decompensate, you just suddenly notice. So keep a high index of suspicion, my other favorite words.
Yeah.
All right, so the hemothorax, hemo, meaning blood, fills into that chest cavity, causing the same kind of thing that the pneumothorax would cause. Then there's hemopneumothorax. I think they just like using long words in medical terms. It's just blood and air. So here's some examples of each. So if it's completely filled with blood, hemothorax. What can we do pre-hospitally to fix that?
Drive fast.
Drive fast. Diesel therapy. So in hospital treatment is gonna be like a chest tube. So if we get our critical care out here and we can start doing finger thoracotomies, that'll help with that. That whenever we stick a needle in, that needle is not wide enough to let all of that blood out. So you gotta create a hole somehow and get that blood out of there, basically. So, same-ish kinds of signs and symptoms as a pneumothorax, whenever we're talking about a hemothorax, because it's almost the same physiology, right? That lung is being crushed. But some other things that you might see is them like coughing or spitting up blood. Another big like test question differential between a hemothorax and a pneumothorax is they actually don't get JVD. Their neck veins flat. Why is that? Yeah, the blood, there's nothing backing up into it. They're losing blood into their chest. Good job. All right. So compression and shearing injuries. Whenever we're talking about shearing injuries, we think of like the biggest one, the most concerning, is gonna be like an aortic shearing injury from being hit, usually like a T-bone, and their little organs do this number, and their aorta's like, see you later. So, yeah, good night. If that happens and they're bleeding significantly, there's not a lot you can do for that, right? They need a surgeon right there. Another thing, chest injuries, they can be considered open or closed. What do you think is the difference between open and closed?
When the skin is broken.
Yeah, the skin. One's skin's open, one's closed. So kind of easy. Here, this is the best little picture. Sorry, it's not a GIF. This is the best little picture I could find of that aorta. So we have an aortic arch. So a shearing is like it gets pulled from side to side and it'll shear. And then there's bending where it'll actually like clamp it off and then put it back. And so we can like, you can get a either a dissection, like an aortic dissection, or like an aneurysm from this. So not always is it just gonna completely rip and die. Sometimes it causes enough injury that they start to get that ballooning effect. And then torsion is actually just twisting. So these are things to be kind of on high suspicion for on like those T-bone injuries, major falls where they're like landing on something that can cause it too. Traumatic asphyxia. So compression of the chest causes a buildup of blood. They can't breathe, right? So some things you'll see is like this purpling blue of their chest that goes up to their head. Their eyes, we call it like a petechial hemorrhage. So the petechiae, like these little blood vessels here in the eyes will burst. So you'll see like this redness. This is an extreme case. Sometimes it's not that obvious, but you can see that. See how he's like purple and blue up here? And then another like telltale sign of this is a blue swollen tongue. So this comes into like car accidents, they can get this, machinery falling on them, but then hangings too. So you think about like hanging is a traumatic asphyxiation. So usually their tongue's all swollen up and sticking out and black. So keep, if you're going on an accident and there's like a possibility of this and you're seeing these signs and symptoms, also be on the lookout for that pneumothorax, that hemothorax, because there was a lot of trauma to that chest. Cardiac tamponade. So there's a little sac that likes to hang out around our heart called our pericardium. So if there's any damage to the heart, we can actually start filling that sac up, right? So there's like a triad. You guys, as we're going through like trauma stuff, you're gonna hear a lot of triads. So 3 signs and symptoms that tell you that this one thing is going on. So for a cardiac tamponade, we actually look for Beck's triad is what it's called. And I think it's either on this slide, yeah. So the 3 Ds of Beck's triad. So think about what's going on, right? This heart sac is filling up with blood. So whenever you go to listen for heart tones, if you do that, I will say in an ambulance, pre-hospital, being able to be like, yep, those are muffled heart tones. It's not really, but some of these other things might help you, right? So distended neck veins, they start to bulge up here. And then they also get a decreased pulse pressure. What is a pulse pressure?
How hard the beating?
Kind of. How would you figure out, like, put a number to that pulse pressure? So you take your systolic number minus your diastolic. So if that number, as you're like assessing every 5 minutes, because this patient's critical, if you look at those numbers start to get closer and closer together, that could be a sign of this. So that's it. All right, here's your aortic injuries. So these should be reviewed. So this can be caused from like a sudden onset of an aortic injury, or it could be like a traumatic cause too. Right, so like our AAAs, your textbook AAAs, they were standing there, they had chest pain that radiated to their back. It's like more of a medical call. It can happen in trauma patients as well. So a lot of the same signs and symptoms, chest pain, shearing pain, radiates to their back. Why does it radiate to their back? Does anybody remember? We went over it last week. Referral? Huh?
Is it referral?
Not so much referral, but part of our aorta sits in our retroperitoneal space. So it can radiate to the back. So signs of shock. What's our signs of shock?
Pale diaphoretic.
What happens to the heart rate? What happens to their blood pressure? Goes down, yes. Another thing, differences in pulse, same kind of thing as like a medical aortic problem. You might feel a difference in those pulses on each side or differences in blood pressures. Another thing to look for is like discoloration of one limb over the other. That can kind of give you an index of suspicion that something like this is going on. I think this is just a video of, oh, yes.
Foosball.
I remember this game.
That's not what any of us want to see, and everybody's around him, and just hope that he's going to be okay.
So we'll take another break here in Cincinnati.
So you get called to a football field for a 25-year-old in cardiac arrest, and you see this video. What do you think happened? Yeah, commotio cordis. So, commotio cordis. I don't even know if I'm saying that right. So it is uncommon. So for him, he got hit in the chest, and then he said, "I'm taking the dirt," but he came back, so he wasn't really taking the real dirt now. So this is uncommon. So for this to happen, they have to be hit in the chest at the exact right millisecond. So to kind of put it into perspective, this is your, like, the top right part, your atria contracting, your ventricles contracting, and then they're starting to relax, right? Our heartbeat 60 times a minute, 60 to 100. So for it to hit right here as it's relaxing in this tiny little window, it can cause them to go into arrhythmia. So very rare. Causes VFib, can cause VTAC. This is going to be like your textbook scenario of this. Is you get called to a baseball field for an 8-year-old that got hit in the chest while playing baseball, and now he's in cardiac arrest. What do you think's going on with this patient? Is your answer. So, treat them, CPR, early defibrillation, the whole chain of life, right? And kind of thing. Yeah. Gross.
Yeah.
All right, abdominal injuries classified the same way. This is gonna be a common theme as we go through like head and neck. Abdominal injuries, musculoskeletal, they all can be open or closed, right? So that's kind of obvious. Is this an open or closed injury? This is very open. Yeah, if you're seeing this, that's not good. It looks like a brain sitting on that little bone.
That's what I thought.
Yeah, not a brain. So keep in mind that all that vasculature that sits in our belly and in our chest, and especially our belly, there's a lot of vasculature there. So internal injuries can bleed a lot. And sometimes they bleed out before you really even realize it. And now you're dealing with a half-dead patient and it sucks. That's called evisceration. All right, so we have blunt trauma, penetrating trauma, all that fun stuff. So blood loss, this is that disruption of the diaphragm that I was telling you all about. It's kind of hard to tell if you don't know what you're looking at, but like this is their belly, their stomach. This is their lung cavity. So it should not be there. That's a bad day. If you ever go to listen to lungs and you hear vowel sounds, start trying that. So injury to the diaphragm, it takes a lot to injure a diaphragm, but it is possible. So keep that in mind because whenever we're looking at injury patterns, we're looking at the mechanism of injury too. Like did they get tossed out of an airplane or did they trip and fall? So think of like how they could be hurt with looking at their vehicle, seeing how their car is sitting, seeing what they fell onto. Did they fall on the carpet? Did they fall off a ledge? Did they just trip and fall on the concrete? These are all things that you should be thinking of so you can start thinking of injury patterns. So we talked about the hollow organs causing sepsis and peritonitis. What are some signs and symptoms that you might see? Say you go on an NBC and you are kind of suspicious of trauma to the abdomen. What kinds of things are you going to look for to kind of confirm your suspicions? Bruising? Swelling?
Coffee grounds,
Bleeding.
cough up.
Maybe. It might take a little bit to get to that point. Bleeding? Yeah. What else? What happens when your belly gets irritated? What does it start to do? Starts to fill with blood. Distension, bloating, yeah. How do you think they're gonna present if they have a bad? Are they gonna be like walking up to you like, hey, how's it going today? What are they gonna do? They're gonna like hunch over or like fetal position, right? So they bring their knees up to take that extra pressure off those muscles on their belly. So a lot of times that's the most comfortable position. Cramps, nausea, weakness, thirst, signs of shock. Obviously, if they have a big old cut on their belly, that's a sign. Rigid, tender, rigid. So if you're feeling their belly and you're feeling something hard in there, feels like there's a hard lump, that's a problem. There's the fecal position. I call it the fecal position because you feel shit. So make sure you're trying to manage their airway with abdominal stuff. People like to vomit. Any kind. This is any kind of treatment. Watch for vomiting because patients like to vomit. If they're more comfortable laying like this on your stretcher, don't be like, straighten your legs and like crank them down. If they're comfortable like this, we're gonna put the seatbelts on as best we can and let them be comfortable. What does NPO mean? Yeah, nothing by mouth. So our patients' general rule of thumb, if they're like, can I eat before we go? Can I drink before we go to the hospital? Usually your best answer is gonna be no, unless it's a diabetic patient who wants them to eat. If they're hypoglycemic, right? Because if they have to go into surgery, it can cause more complications, or if they're having any kind of damage, injury to their belly. Control your bleeding. So if there's obvious hemorrhage, we're still gonna bandage any kind of like bleeding that's going on, whether we do it first or last. Is it a lot of blood? Is it a little blood? We're still gonna assess it. Do not try to push the eviscerated organs back into their belly. Ugh. And then, like I said, if it's wet, if that organ is wet before it came out, or if it's injured, keep it wet. So eyeballs, organs, that kind of stuff, try and keep it wet. With sterile saline, try and wrap it. They usually say like some kind of plastic wrap or something to kind of hold everything. And then make sure you're treating for shock. Here's that path of the bullet. So this is just a few examples of what happens whenever a bullet enters the body. Obviously, this is dependent on the bullet. But these are just some things we see. So as it enters, it gets like this little cavitation. And anything in the area of this is going to get injured. That bullet could break apart. Those little pieces can cause more problems. Can go straight through. Sometimes it doesn't go straight through and it starts to go and bounces around and hits everything else on its way out. If it even comes out, sometimes they spread. So keep this in mind whenever you're treating GSWs. Because I've been on GSWs before where they're like shot in the belly and up here in the chest. And as I felt their spine, I could feel the bullet up here by their neck. So bullets travel. This
That's right.
is the thing.
The
This is
thing.
what all the hip kids are talking about these days. So this is a diamond now. I'm gonna start out easy with the triad, so just 3 of them. So in a trauma patient, these 3 things, or 4, but these 3 things are gonna kill your trauma patient if you don't treat them. And if you are doing something that counteracts any one of these 3, you're not helping them. You can cause long-term problems. You can cause short-term problems. What is coagulopathy? We talked about that. Yeah, how well our blood clots, right? So a general rule of thumb these all work together, right? General rule of thumb, cold blood does not clot. So you want to keep your patients warm, and you don't want to shove them full of IV fluids. I know you guys can't do that right now, but if you're ever working with somebody and they're like, bolus all the fluids, keep that in mind, that you're actively working against their clotting cascade. You are working against the patient. Okay, and then acidosis is another one, right? So cold patients, they get acidotic. The fluids that we give pre-hospitally are all acidotic, right? Because our pH of our body is 7.35 to 7.45, and none of the crystalloid fluids that we carry on an ambulance fit that criteria. So you're working against them in every single way. Hypothermia, our fluids are not warm. Coagulopathy, we're taking away all their clotting factors. We're turning their blood into watered down Kool-Aid, so they're not able to clot. And then we're making them acidotic. So this is a big thing. Keep all of this stuff in mind, right? This is why whenever we treat for shock, we cover them with a blanket, we give them oxygen, all that fun stuff. You're working with the patient. And questions? Nope. Okay. I'm discard that. You guys want to take a quick 5-minute break?
Along with all the stuff,
Yeah.
This conference will now be recorded.
Tell the story to everybody. Yeah. He's usually in the 501. Yeah. But it's only one on it.
He said, hey.
Yeah, hey, Fran.
It's not very.
Oh, he did.
Fun fact, he doesn't do this.
Wow.
That would piss me off too. I told him that too.
They actually
Yeah, that's what.
Yeah.
That's what's happening.
Yeah.
I'm trying to be I'm sure. He's already said that. Yeah, he said, it was like the day I asked him to, he's like, yeah, what are we gonna do? So they're calling this, you know, I got on my truck and I told him.
I see fucking shit.
He said he got out and told you fire him.
You're my help for the day.
Austin.
I mean, just do it. Someone has to be accountable.
All right,
So
real quick.
I have I've printed out instructions for you guys to sign into NREMT. You have to do this to be able to test at the end of this, right? So a lot of these stuff, like everything past step 4, like you don't have to do step 4 right now. Do step 1, 2, and 3, and then I'll let you know when we have to go on to 4 and the rest of them. But you need to do the first 3 steps at least as soon as possible. So I have printed out for you a step-by-step instruction because Mr. Lake needs things very spelled out for him.
I appreciate that.
To be able to accomplish anything in a timely fashion here. Austin, you have this. I've emailed it to Matt, so Matt can get you this. If for some reason you cannot do this, come find one of us. We can help you through it. We'll, breastfeed you through this process. Dr. Lake, you never should have said nothing about my shoes. Texting me about my shoes is where you messed up. So please get this done in the next 24 hours so that you can test at the end of this. Okay? If you mess this up, you cannot test. You have to test at a Pearson View site, and you have to be on the NREMT website to be able for me to approve you, and then you'll end up getting a letter, which is your ATT letter, which is your approval.
Test.
Yeah, a tentative test. Right. So, yeah, right. So,
So listen, with these national registry things, they're pretty self-explanatory. It's a little bit easier to get the initial login for the state. You just go in there and create a profile, and then basically that thing's going to sit null all the way up until a couple of weeks before we finish class. And then a couple of weeks before we finish class, you'll get the attempt to test little thing that'll pop up on there, and then you'll have to go in there, select a date and a location in which you're going to go take your test, and then you'll go down, take your test, and then you get to sit there and refresh your phone every 20 minutes for the next 48 hours until the score comes back.
So I'm gonna leave these on the end right here. Don't leave without one. Again, if you're unsuccessful, then come find one of us so we can help get you through it, okay?
What's the closest testing center here?
Elko.
Elko.
Elko has a Pearson View Center, and let me tell you right now, I've tested there 3 times, passed all 3 times. Just pick the second row, 4th chair in, it's a lucky one. If I got through it 3 times in a row, y'all will be fine.
We're not testing here.
We need to.
Oh, no, sorry. That is false. We have enough students that the state will come down and put a test here.
Oh,
You're right. Yeah,
oh, they'll bring that?
yeah. They will bring, the state will come down and proctor your test somewhere around here.
Oh, that's good. Did
Here's
Austin get an email about this?
I did email Austin.
So,
No, the state will do it on behalf of Pearson here.
so I can tell you this, when you come in for that Pearson test, expect to tell all your loved ones, family, and friends that you will be unavailable for the preceding 2 hours. Just be warned. Tell them you love them, tell them you'll talk to them in 2 hours, because when you walk into those tests, well, if something happens, you better tell them to come up here, because they're not gonna be able to get in touch with you. They're gonna take all your phones, they're gonna have you empty your pockets, you're not gonna be able to bring anything in here except for the piece of paper that they give you and a pen. That is it.
No watches, no anything. And if you get caught trying to cheat on this test, you're like, that's it. It's
You'll
over.
never work in
You'll
EMS.
never work in EMS.
You'll never
They will
have
blackball you. Yeah, you'll be done.
Most of the Pearson test you centers you have, you walk in there and they've got like 6 cameras that watch you at all times. So they are very serious about it. It is a very, very strict process. So just expect, I'm letting you know now, that if you come in here to test, just tell your family and loved ones that if something happens, they better call 911, because they ain't gonna be able to get in touch with you.
We've got a bunch of tattoos.
Oh, they'll look at you.
Yeah, they take your glasses off and look at the inside.
Oh, man.
Your hats, if you wear a hat, they take your hats off.
Millions of straps.
Play squat off too.
I don't know, lady, I'm just trying to see.
Are they gonna consider all my scratches in my glasses?
All right, we're gonna run through this real quick so we can do this case study and get y'all out of here.
Yeah, all right, so musculoskeletal. All right, so review A&P of the musculoskeletal system. Again, this should be review, different types of injuries in the musculoskeletal system. And then learn how to splint and why do we splint. We're gonna do all that stuff. What is the musculoskeletal system? Bones is muscles, ligaments, tendons, cartilage, all that kind of fun stuff. So the bones, that's how today's going. The bones are the framework. Our joints allow us to bend, right? Muscles allow movement. Cartilage is the flexibility. Ligaments are a bone-to-bone connection. And then tendons are a muscle-to-bone connection. This might not work for y'all. This is just how it works in my brain. I think ligaments, it reminds me of the word leg. And our leg has like two big bones. It has 3, but 2 big bones in it. So that's how I remember it, bone to bone. That's how I remember. There might be an easier way. That might seem silly. That's just how it sticks in my brain. So, here's some of our bones. I brought in Skelly if y'all want to pass them around so you can look at the bones. So, another thing I did want to mention, that test talked about like proximal and distal. What is proximal? Towards the core, right? And then distal is what? Further away because it's a distance. So like our phalanges are distal to our humerus kind of thing. All right. So bones. So anatomy of a bone. So they are formed of dense connective tissues. Obviously they're hard. They shouldn't be too bendy. Whenever we're kids, they actually are kind of bendy. We'll talk about that. They are vascular. So this is like a bone cut in half, or like a slice of bone. You can see that they're vascular as well. So our bones bleed, right? So it's got arteries and veins running up inside of it. There's arteries and veins running out around it. And then this, anytime you see like osteo, that is referring to bones. So osteoporosis, osteomyelitis, that's infection of the bone. Osteomyelitis is infection of the bone. So keep that in mind when it comes to osteo, whenever we're talking about medical terminology. And then joints are where our bones meet. That's kind of gotta talk about it. All right, so our bones can bleed, but how much can our bones bleed? Right? How much fluid can go in there? So just to put into perspective, our whole body holds 8 to 10 pints of blood. That is dependent on like your size, your stature, your age, if you're a male or a female. Males tend to be on like a higher side of how many pints, and women are on the lower side. So about 20% of blood loss leads to a decompensated shock state. What is 20% of 10? 2. All right, 20%. Keep that in mind. 2 pints. Our pelvis, 3 to 4 pints. That's a lot of blood in comparison to our body. Almost, it could be half if you're on the lower end. 50% of your blood can be lost into your pelvis. Right? That's a big area. Our femur, that's 2 pints. That's that 20% that's going to put you into decompensated shock. And then tib fib is 1 pint. So these can be significant. These are things that you need to keep in mind. The biggest one is that pelvis, right? All right, so this skeleton split up into 2 different things. We have our axial skeleton. This is like the center part. Then we have your appendicular skeleton, so our appendages, our arms and legs, pelvis. So our bones are classified by shape. Are they a long bone? Are they a short bone? Are they a flat bone? Are they irregular? So our vertebrae, they're very irregular looking. They're not like flat or long. Or whenever we're talking about long bones, that's like our humerus, radius, ulna, tib fib, humerus. Our scapula is flat, so it's a flat bone. And then we got our little short bones in our feet and in our hands. So it's important to know like long bone and joints whenever it comes to splinting. So that's important to know. Like if we're splinting a long bone, we want to make sure that the joint above and below is not able to move. Yeah. All right, so bones can heal. So what happens is this little break, the soft tissue around the bone starts to swell. Our body's sending blood to that area to try and heal, right? So these cells start to die. This is painful. Like our bones are surrounded by like pain sensors. So like someone pops a bone, it's gonna hurt, right? That's kind of common sense. And then as they start to heal, the cells divide. We get new bone. So depending on like how long ago that break was, they can heal in weird deformed shapes too. So keep that in mind if you're dealing with like Meemaw. I've picked up a Meemaw before and her arms all like that. And I'm like, what happened? And she's like, I broke my arm 7 years ago and I never got it healed. So it's all like angulated. So it can heal in the like shape that it's in. If that makes sense. All right, and then we have our muscle tissue. So we have 3 kinds. We have smooth, we have cardiac, and we have our striated. Which one's voluntary? Which one's involuntary? Smooth, yep. Good job. And then cardiac is your myocardial. My favorite. All right, and then we have our cartilage. So that allows us to be a little bit more bendy. Tip of your nose, that's cartilage. The cartilage that goes around your sternum, that's cartilage. It allows it to be a little bit bendy, right? Got cartilage in our ears. Tendons allow for movement across joints. So another way to remember this never stays in my head, but it should work for you. MTB, muscle, tendon, bone. So what they're talking about, this is your muscle, tendon, hooks on the bone. And then you have your ligaments, which is BLB, which if you look here, this bone, ligament, bone. It connects the 2 bones together, and then that cartilage goes in between. Does that make sense? Okay. And these are hard for my brain to remember. And I remember there being test questions about them, and I just like memorized them for a moment, and then kept forgetting them. So you try and learn like the little ways to remember. That might help you. So mechanisms of injury whenever it comes to a musculoskeletal problem, you have a direct force. So something hitting that, or if you fall and catch yourself, your hand hitting the ground, that's your direct force. Your indirect force is like you fall and hit the ground and everything gets shoved up and you hurt your shoulder. That's an indirect force. So like you can see. Another thing that can be considered like an indirect force is like whenever we're talking about someone falling from a big height and they land on their heels, they get this indirect compression injury to their spine. And then twisting. So the common one for that, skiing, because everyone breaks their knees while they ski, and twist and break ligaments, and all that fun stuff. So 3 different kinds. This kind of helps, like if you were asking, like, what happened? Oh, I fell and I caught myself and dislocated my elbow. You can kind of get a sense of why something happened. So the definition of a fracture: any break in a bone, whether it is open or closed. Like I said, that's going to be a common theme here. Open or closed, right? So there's different types of bone fractures, and then those bones can also do weird little shape things. So that's what we're talking about here. So your green stick fracture, it kind of like bows out and doesn't break all the way through. This is the most common in children because they're bendy. So if a kid breaks a bone and they're pretty young and they have healthy bones, most of the time it's got to be like some kind of green stick fracture. Transverse, all the way through, like clean break. I don't even know how to say this. Comminuted? It breaks apart into a bunch of little pieces. Spiral, it comes up in spirals as it breaks, and then compound is like at that diagonal, it shears off. So from there, it can be completely displaced, it can be angulated, it can be shortened. That's really big whenever we're talking about like hip fractures and femur fractures, because those legs will be shortened. Like you'll see their foot actually come up a lot higher than the other one, and then rotated. So that's also dealing with like your femur fractures. So textbook femur fracture is going to be shortened and rotated foot, and we'll show you some examples of that. So dislocation, that is a kneecap on the wrong side of the leg. It makes me cringe every time I think about it. So remember, kneecaps, they can go this way or they can go this way. So they can either go medial or they can go lateral. If they've already had a dislocated knee, they're more prone to have another one. So if you've ever known anyone that has had dislocated knees, sometimes they're just like, oh, it's dislocated again, and they'll pop it back in and just keep doing whatever they're doing. Sprain and strain, I don't have anything fancy to remember the difference between the two. but there is a difference. So the sprain with a P is the ligament damage, and then the strain is the muscle damage. I don't even have a good way for y'all to remember that, but sometimes it's good to know the difference. Maybe strain like striated muscle. You can remember striated muscle. I don't even know. I got nothing.
Mr. T is a muscle guy.
Oh, that's a good one. Mr. T is a muscle guy. I like it. All right. So assessment tips of musculoskeletal injury. If they deserve to get trauma naked, get them trauma naked. Right? If they have a significant mechanism of injury, if they're altered, then you need to do a full assessment. Cut their clothes off. Right? And then we're going to keep them warm. But yes, cut their clothes off so you can see. Sometimes they talk about like distracting injuries. Not only is it distracting for the patient because they're like, oh, my leg's broken, and they forget that they're like bleeding out over here. It can be distracting for you too. So you might have like a really gnarly looking wound, like a degloved arm or something, but their femur's broken, they're bleeding into their leg. So these are things that you want to do a full assessment on. This is the reason for that rapid trauma assessment. You want to assess everything. Yeah, so complete examination, address life-threatening conditions first, do your ABCs, all that. So whenever we're splinting, if you suspect a fracture, treat it like a fracture. Splint it. Some nurses are weird about this. I haven't ran into it so much around here. But if you're like, yeah, they have a fracture of their arm, you can't diagnose a fracture. Whatever. They have a crepitus, like deformity to their left arm, whatever. So technically you can't diagnose in the field. If you have a suspected femur fracture, mid-shaft femur fracture, we're going to put a traction splint on. So we're going to go over that mostly on Saturday. We're going to go over all the splinting, backing again, and all that fun stuff. So I will say in my tenure of doing EMS, if somebody has like a femur fracture or a broken arm, I've given them pain meds and it doesn't even touch it, but as soon as I splint it, they're like, oh, that feels so much better. Because those bones are moving around and they hurt. And as soon as you get them held in place or back where they need to go, a lot of times that removes a lot of the pain. So keep that in mind. And then what's CMS? CMS, PMS, CSM.
Circulation, motor skill,
Yeah.
sensory.
Yep. So let's say Chaz has a broken arm and it's all like to the side. When am I going to check CSM or CMS? Before and after. All right, so his arm's all bent to the side. I'm feeling for a pulse. I don't feel a pulse. And his fingers are turning blue. What do I do? Call an adult. So you get one chance to put it back where it should go. So they're going to scream at you. But if you don't have pulses or any kind of diminished anything in their arms, like you or leg or whatever, you get one more chance to like pop it back and then go for a pulse and then splint, go for a pulse after you splint. That's a big thing. Check before and after any kind of splint. What do you do if you have good pulses, motor sensory? I go through the whole motion of splinting his arm and I go to check it again and now it's gone. What do I do?
Have slight traction.
You can, or just take your splint off and try it again because sometimes we crank down on those splints and it cuts off circulation. So keep that in mind too. We get all excited.
So what happens if you have that one option to move it once? What do you do if you still don't move?
Drive fast.
Drive really fast. Because if you, like, say it's displaced, like, and you don't have a pulse or anything, you move it back to anatomical position or where their arm should be, it's now in line, there's nothing you can really do from that point. You can try, like, a manual traction thing if it's something like a displaced fracture and you're, like, bringing it back together. You can try doing something like that. But if, like, you put it back and it's like an elbow thing, or, like, can't get pulses, drive fast. That's surgical interventions. All right, types of splints. Everybody's favorite, triangle bandage. Everybody hates that one, to be honest. There's actually a better way to do it that I just learned the other day that I wish I would have known for the last 10 years I've been doing this. But This is what your triangle splint looks like as you pull it out. You're gonna take your corner, you're gonna tie a little tiny knot in it, like this. So what that does, you wanna scoot this way so you're in front of the camera?
No.
Please. Perfect. So what that does is it allows a little cubby for their elbow to sit in. So as you're bringing this up as a sling and swath, and a little elbow has support. So yeah, that's great. Whatever. F that thing. So what we're gonna do is take Coban. You can actually do the same thing. So obviously you're not gonna put this directly over like a broken bone sticking out. You're gonna support the wrist. Go up and around. My Coban's not long enough, but put it there and then go around, and now it's a sling and swath. Way better than that thing. Everybody messes with that thing, it's a pain in the butt. The most important thing, everybody forgets about this swath part. They always remember the sling part, but they forget the swath part. The swath is immobilizing that, so it can't move out anymore. So you need to do both. What are these things right here? Traction splints. Good. Must be 7. What's this?
Vacuum splint?
It is a vacuum splint. Got our Lcems splints, another traction splint, a cute little finger splint. Aw, cardboard works in a pinch.
Or if you work in a big city, you get cardboard.
Yeah.
Ew.
Yeah. That's an icky day. So why do we splint? Prevent injury, help with pain, or something else. Immobilize, yeah, good job. So if you're minimizing the movement in those extremities, you're gonna help with all of that. So those bones, as they move around, they can cause shearing forces inside, whether it's a closed or open fracture. There is a possibility that if you don't secure it, or if you secure it incorrectly and splint it incorrectly, that your closed fracture will turn into an open fracture. So be mindful of that. I think this is what I said. So when splinting a joint, the long bone above and below needs to be immobilized. So if it's an elbow, this bone and this bone need to be immobilized. If it's a shoulder, obviously I can't splint the scapula, so I'm going to splint the long bone below it. If it's a leg, joint above and below. If it's a joint that's injured, vice versa. I said that funky. Either way, either side of it needs to be immobilized. What is wrong, speaking on that note, what is wrong with the location of this cardboard splint?
A firefighter did it.
Yeah, firefighter did this. So what's this, right? This is where it cuts off.
No ankle support.
Yeah, there's no ankle support. This joint is not immobilized. So if we kept this like it was, right here, closed up, tied up, his foot's gonna be sitting there doing this number while we're bouncing down the road. Is that gonna help him? No. This dude got smacked by a car.
On a motorcycle.
On a motorcycle. All right, this is also another option, pillow splints. I love pillow splints for ankle injuries. You just wrap a little pillow up around their foot and tape it down. Works fantastic. Finger splints, you can get like a piece of the actual splint part and splint their finger, or you can tie their fingers together if it comes to it. This is a wonderful option for messed up knees. So if they can't straighten their knee for whatever reason, you take 2 like boards or Lcems splints if they're long enough and go on either side and do like a figure 8 wrap around it to immobilize it. We just talked about this. If you have an obviously like not in place injury, and you can't feel a pulse, or they can't move their fingers, or they're turning blue, or their foot, or whatever, pop it back in. Or try to at least get it into alignment. Whenever you are securing a splint, make sure that you keep their limbs in a position of function. So what we mean by that is if you're doing an arm, one of the best things you can do, so if he put the SAM splint on me. I'm gonna stand in front of this. He puts the SAM splint on me. I'm not gonna splint all their fingers straight out. I'm gonna have them hold on to a piece of gauze, just so it's comfortable. It just feels right. Like if you were like thinking about how you do it, it just feels right to kind of rest your hand like this rather than like taking your whole hand down like this. Does that make sense? So with the foot, don't point it with their toes pointed down. You want their foot like keep it angled. So this foot obviously has the wrong kind of angle to it. But
You see the little X on the top of his foot?
Yeah.
Where's that?
For the pulses.
Yeah. So if you find a pulse in that extremity, you can leave it there, just mark it, because you might have a hard time finding it later.
all right, pelvic injuries. How do we treat a possible pelvic injury? Good job. Yeah, so these are some signs and symptoms: an unexplained pressure in the bladder. Sometimes they'll get discoloration in their like genitals, so their nuts will turn purple. Yeah. This also plays into that shortened and rotated, usually rotated. There's a type of pelvic fracture called an open book fracture. It looks like this. So this little part, you should be married. You're divorced.
This guy was also in a motorcycle accident.
Oh, this wasn't our guy. I couldn't find that picture.
Oh, I got it. But this guy was probably also in a motorcycle accident. Key point here, stay off motorcycle.
Yeah. So with an open book pelvic injury like this, they get this very distinctive like frog leg look to them. Like you'll walk up and their legs are like looking like this on scene, and you should be like, oh, look like that. Okay. Try to put it on before you get to moving around too much because your whole pelvis is gonna be moving around. That is why. That is the vasculature inside of your pelvis. So a fracture that's displaced or chipped off or moving around, there's a lot of real estate here for it to get severed. And then you remember how much blood a pelvis can hold? 3 to 4 pints. Yeah. So we put one of them on. It's a pelvic splint. There's a bunch of different kinds. The key takeaway here is you should be putting a pelvic splint on like a mini skirt and not a WWE belt. WWE belt. So you don't want it up here, up by their belly button. You actually just want to cover it like you would a mini skirt. Go right around here. So you can see that it's down further. Your femur sticks up here and goes into the acetabulum is the name of it. And it's your greater trochanter is right where that came from. Can't talk today. Your femur goes into your greater trochanter, so you want to keep it low. So this is a T-pod. This is up a little bit high. That's a SAM splint. You can use a sheet if you're in a pinch. So take a sheet, lay them on the sheet, cross them, hold, and then secure it. It can act the same. It's holding everything in place. Your hip dislocation, this is where you get like your shortened and rotated. So you can see this. And I was always taught diapose, so dislocation, the leg goes inward, fracture, the leg goes outward. That's not always the case. That's just kind of like a general thing. So it can be either a posterior where that hip bone pops behind the pelvis, or it can be anterior where that hip bone pops in front of the pelvis. So very painful. Geriatric patients are very susceptible to this. If they own the lower bones, they got the osteoporosis. Hip fracture, usually it's a localized pain. They can point right where it hurts. Here's that greater trochanter. So if you're like feeling around and you poke it, and you're like, ah. Suspect this. You might see some bruising, swelling. If they can't stand, they probably got something going on. And then shortened and rotated limbs. So you can see how this foot's shorter than that foot and it's rotated. So if you walk up on scene for whatever reason, Grandma Meemaw fell in the middle of the night, she's laying on the bathroom floor and it looks like that.
Don't straighten it.
Yeah. Don't straighten it. They will yell at you. You can try and kind of like support it a little bit I've used pelvic binders for this reason to kind of hold everything in place. Because I can't diagnose, so I don't know if it's pelvic fracture. But I'll do that and kind of hold it. And then your femoral head. This was the best picture I could find on Google. But whenever they have a closed, this one's open, obviously, but when they do have a closed femur fracture, they get this very distinctive like buckle, like a buckling of the skin, like this line right here. And it can be anywhere here. So keep that in mind. That's not something that you really see a lot in like your textbooks, but just from doing this for a little bit and seeing some femur fractures, that's what it'll look like. It kind of this little buckling thing. So traction splint, have your partner hold manual traction before you put the traction splint on.
You get multiple buckle or just like one?
So most of
Usually
the
just
time,
one.
yeah, wherever that break is, you can kind of isolate it because you'll see it kind of like looks like the skin around is just sinking in, and so there'll just be like a line all the way around.
And that's usually where the break is.
Yeah.
Oh, okay.
Y'all want to take a quick break? What time is it? Oh, it's 7:10.
So
So
TikTok has a thing for when they're ready to ligament thing. Because the guy's like, should remember ligma. Like, ligma bone.
Oh,
It's like, is that, yeah.
That's funny.
I was sitting there watching that, like, oh.
where are you going?
But it actually makes sense now.
Yeah.
I thought he was just being a name.
Yeah, that's a good way to remember it.
I should close the door.
Trap us.
All right. We're going to do this case study real quick. It's going to touch on a handful of things we talked about in this class over and over again. So in North Carolina, there was a medical director that basically stated that your ability to live through a traumatic or medical related event should not be depicted on where you live. Right? So basically what that means is years and years ago, there was this old saying that if you got hurt in the middle of nowhere, you were going to die in the middle of nowhere. We're trying to change that stigma, right? If you go into cardiac arrest and you know, down a mountain, you shouldn't have to die here just because you had a medical emergency. Same thing with traumatic emergency. As most of you know at this point, I've gotten permission from Calvin to talk about this. He has reviewed this. I have done this class or done this case study in front of our office staff. He's reviewed it. He likes it. So we're going to keep talking about it. At some point, I would like to be able to show this to people outside of just this community, because what a lot of people don't realize is what happened to Calvin, though an unfortunate incident, shined a lot of light in the fact that you don't have to die in the town just because you got hurt in a small community, right? We were able to rapidly extricate him out of here, get him on a helicopter and get him where he needed to go. Because what does he need? Surgery, right? We can't do anything in Battle Mountain. They can't cut him open in Battle Mountain and go in there and stitch him all up and make everything look good again. So what we're trying to do is stabilize him as best as we can and get him out of here. So a lot of these case studies that you'll see, if you stay in this for a little bit, they're very, very informative. They are real life situations, and they have permission to use these situations while avoiding some HIPAA violations, right? Again, I've got permission from Calvin, so I'm not violating any. So, an introduction to this case. We got paged out one morning to a 27-year-old male with a GSW to the app. Again, this is a very, very big case on interagency cooperations from the Sheriff's Department, from EMS, from the hospital. The hospital staff that day just happened to be probably the best group of people that we could have at that hospital. The doctors, the nurses, everybody there was probably the best group that we could have had that day. It was a very fortunate situation for us, for Calvin, that those people were there that day in particular to be able to perform the things that we were able to perform. So, the clinical presentation. So, this young man had a entrance and exit wound, even though we're not allowed to officially diagnose either one. He had 2 penetrating injuries, one to the front upper right-hand quadrant and one to his back. So when we arrived on scene, we had a patient with a G-test of 15, cool, pale, and diaphoretic. What does that tell you? So he's in some sort of shock at this point, right? He had strong radial pulses on initial contact, but he had absent lung sounds on the right side, and he told us that he could not exhale. So we got him in the back of the ambulance, and he said, I can't exhale, and I'm diaphoretic, right? It's kind of a double-edged sword because he's smart enough to know what's going on with him, so he's smart enough to know that he's sick. That makes the situation a little bit more difficult for us just because we know that he knows that he's sick, right? So, early recognition for treatments. So we arrived at 9:27 in the morning. He was quickly put on a neck mover and moved out to the ambulance. Again, he was cold pill diaphoretic. We did not need to spend time in his house having a conversation with him. His dog was kind of angry at us at the time, so we were not trying to get bit. Casper is a very lovely animal. He's kind of angry. So this is our first set of vitals that we got. I'm not super confident in that first blood pressure. This is the first blood pressure that popped up on the monitor. We were trying to do a lot of things, but what do you see with his oxygen saturation? Right? So, what time is that? And what time is that? What's the difference? 2 minutes. Right? That's why I'm not super confident in that blood pressure, but that's one that popped up on the monitor. This is the second blood pressure, second set of vitals that we got 2 minutes later. At this point, we're in the back of the ambulance. What does this set of vitals tell you? Is he in a compensated state or a decompensated?
Decompensated.
Right? So his entitle's low, so he's not taking good breaths. He's been breathing, he was breathing a little fast, but he's not taking really good respirations. His oxygen sac come up, obviously, because we put him on a little bit of O's, but his heart rate's elevated, his blood pressure's low. This was 2 minutes after that first set of vitals, right? 5 minutes later, this was his vitals. So what do you think? Is he in a compensated or decompensated state now? Right. So he's compensating at this point, right? So due to the absent lung sounds on the right side, his decompensated state with the hypotension, the elevated blood pressure, or the elevated heart rate, his low oxygen saturation, his inability to take a good breath, we went ahead and performed a needle decompression on his right side. This right here is what was a big deciding factor in the field on why he's still here, right? You see how much his blood pressure and his vitals changed just from fixing that situation. So that right there shows you how much of a concern and how big of a problem a tension pneumo can pose, right? So keep that in mind. His entitles come back up. He's getting good oxygenation. His O2 sats, still sitting pretty good. His heart rate's come down some. Obviously, he is still at this point, he's still in an excited state because he's got a bullet hole in his tucked under, right? But his blood pressure's come back up, right? So we like it. So this is what Becca was talking about. This is the diamond instead of the triad. What's the difference between this one and the one that y'all looked at earlier? Hypocalcemia. So when you're losing blood, you're losing calcium. And one of the big things here is, and you have to be mindful of this, when you're reintroducing blood products into patients,
the substance that those blood products are preserved in do not contain calcium. They deplete the calcium of those blood products. So when we give blood in the field, we have to replace that calcium. We have calcium on our ambulances, so we have to replace that. At this point, we are trying to hit all of these milestones, right? We're giving him calcium to supplement the loss of blood, as well as the replenishment of blood that we're giving him. We tried to keep him warm. There was a big fight with a 10-fold blanket that ensued between Mr. Harris and Miss Edie Burkhardt. That was rather entertaining. Now, at the time, I was like, what the frick is going on? But now it's rather entertaining. And acidosis, right? So what did Becca say that we don't want to do to these patients as far as like treatments pre-hospitally? What do we not want to give these patients?
More acid.
Yeah. And what do we have on the ambulance that carries a lot of that's acidotic, right? Fluids, right? So we're not going to just take and put two 16-gauge IVs in him, or add 2 bags of saline and just start dumping it in, because that's just going to make him more acidotic, right? If he gets acidotic, is he going to clot properly, right? So when we're looking at trauma patients, we really have to keep all of these things in mind. As BLS providers, the biggest thing that you want to like really shoot for is the hypothermic aspect of it, right? Because you're not allowed to give like fluids and stuff. You're not allowed to give calcium. But a big part of keeping them warm is the coagulopathy part, right? So you want to make sure their body can appropriately clot. And, you know, without surgical interventions, helping that clotting factor helps him, because he's 2.5 hours out from a trauma center from the time that it happened to the time that he actually sees a trauma surgeon. He's 2.5 hours. By the time we get the flight down here, they get him packaged up, load him on the helicopter, right? Because we're not, I don't care what anybody tells you, when you're calling these flight companies and you're like, hey man, I got a really bad trauma, I need you down here right now. It takes them about 45 minutes at minimum to get here. They like to stand around and freaking finger each other's butthole for another 30 minutes. And then they finally get the patient out of here, and then they have an hour flight down to wherever they're going, right? So you're 2 hours out from them being in the trauma center. So you want to make sure that you're helping their processes. And it sucks. Take your jacket off, whatever you need to do. If you need to sweat in the back of the ambulance, you just sweat in the back of the ambulance, right? So our treatment plan. External bleeding. When the sheriff's department first arrived on scene, like I said, you don't want to take, 3 or 4 rolls of gauze and start stuffing it inside of somebody. If you're running out of gauze trying to stuff an abdomen wound, then that's a problem. Those gauze are going somewhere, right? So what Mr. Smith did, because he was the first one there, was he walked in, he looked at Mr. Calvin, he said, hey buddy, this is gonna hurt real bad. He shoved a couple of little fingers full of gauze down in there and then just put his hand over top of it. Smith did great, right? He did what he was trained to do. He did what he knew how to do at the time, and he did fantastic, right? Calcium, again, because of the trauma diamond, right? We have to take into account that he needs a replenishment of calcium, not only because he's losing it in the loss of blood, but because we're replenishing blood into him, and that stuff does not contain calcium. The decompression. Early recognition of these tension pneumos is important, because as you can see, within 2 minutes, he decompensated, and then probably within another 2 or 3 minutes, he would have gone into cardiac arrest, right? So early recognition of this is important. Passing that information off, if you're calling for ALS or you're getting them to a hospital, at that point, as BLS providers, you can't do that. At that point, you just have to get them to a higher level of care. This hospital is not appropriate for that situation, but if you're riding on the ambulance as a double EMT or an advanced EMT in an EMT truck, you might have to come over to this hospital first, because that has to be something that has to be corrected quick. And pain management. Calvin's new favorite drug is ketamine. You're welcome. I gave him a lot of it. So initially, when he hit the back of the truck, before Becca even said, "Hey, how are you doing?" she pulled down his britches and slapped him in the butt with 50 milligrams of ketamine. Shortly after, we decompressed him because, unfortunately, yeah, my wife's all. But shortly after that, we had to decompress him. We didn't have time to sedate him. We didn't have time to manage his pain before that. I felt bad for that. I'm sorry. And that's what I told him. I was sitting in the back of the truck with him. I looked at him very seductively as his head lay between my legs. And I told him, I said, "Listen, buddy, it's going to hurt real bad, but I need you to sit still." And Becca shoved a 14 gauge needle on the side of his chest. 12 gauge. I figured it was 12. Yeah. Freaking huge, right? That's a freaking pinky sized needle that's going inside your chest. Shortly after that, I looked at Mr. Calvin. I said, "Hey, buddy, I'm about to put you to sleep now." And his only words out of his mouth was, "Yes, please." So I followed it up with 200 milligrams of ketamine, and Mr. Calvin took a fat nap. Somewhere off in cartoon land, he said that it was kind of like looking at a storybook that was like black and white. If you don't know, ketamine is has like psychogenic properties, and it kind of make you hallucinate a little bit. So, Calvin. Does anybody know what TXA is? If you don't, I don't really expect you to. It's something we carry on the ambulance. So it's essentially supposed to help your clotting factors. It's supposed to help your body clot. So if you're bleeding really bad, we get TXA to try to help your body in the clotting process. So we gave him TXA. Unfortunately, like I've said 100 times, when you give people medications, you need to be aware of the consequences of those medications. After we gave Calvin the second 200 milligrams, or the second dose of ketamine, which was 200 milligrams, he had a period of apnea. We were able to recognize it early enough that we just had to bag him for a couple of minutes, and he started breathing spontaneously again, and everything was fine, right? But you have to recognize that. You have to know that when you give somebody medication, especially if you're riding on a truck with a paramedic, and you're giving people sedatives or some sort of depressant, that there's a chance that their respiratory system drops, and you might have to fix that for a few minutes. Most of the time, it doesn't really last that long. Like I said, for him, it felt like it lasted 20 minutes. It was probably like 2, right? And blood administration. So, again, we were fortunate enough to have a hospital staff that worked with us. So we were able to go to the hospital and get 3 units of blood from them. 4 units. 4 units of blood from them. We were administering 2 units of blood on the way to the airport while the flight crew was coming in. Because unfortunately, the flight crew that was coming in was supposed to have blood. If you don't know, there's one flight company in the area that carries blood products. It's Reach. Apparently, they don't carry them all the time. That's a whole other thing. And I've been trying not to yell at people about it. But this particular day, they did not have blood on their helicopter. We were fortunate enough to know that information before they got here. We ran over here, got 4 units. We had 2 units of blood in him before he ever saw that helicopter or ever saw that airplane. And then we put 2 more units on his lap and said, "Here you go, get him to the hospital, don't let him die." Right? So we had a very, very good cooperation. And does anybody know what ANSEP is? If you don't, it's okay. So essentially it's like an antibiotic. So since he had a foreign body enter him, we want to try to prevent any sort of infection. Lucky for him, we did, because apparently Renown didn't at all, and sent him back home septic. So that little ANSEP that we gave him was in there fighting his infection to the death until he had to go back a couple weeks after he got home. So, considerations for transport. We're 3 hours to the closest trauma center from right here.
What is the closest trauma center? Does anybody know? Renown. And I'm pretty sure Renown's only a level 2 trauma center. Right? So the closest level 1 trauma center is what, Utah? University of Utah. Unfortunately, in this state, we can't bypass closer facilities without permission. So because Renown was a closer facility, he had to go down there. Next time, we're going to take him about 100 miles to the east and then call for help. That way they can take him to Utah. Not be it next time. But, so that's a consideration, right? Because if we're putting him in our ambulance and driving him, that's a long ride to try to keep him, you know, stabilized. So at 9:27, when this call come out, I got on the radio and I said, "Hey, dispatch, go ahead and call Reach and have their blood products en route," because that's what they told me to do. Reach said, "If you need blood, tell us you need blood, and we'll bring it to you." I said, "Okay." So that's what I did.
And they still didn't bring it?
So at 9:38, this call went out at 9:27. At 9:38, we went en route to the airport out here for the first time. And I say the first time because we had to leave and go back. Right? So 11 minutes we were at the airport waiting on an aircraft. At 9:40, they called back and told us that they didn't have blood products, but they would be here in 20 minutes. That's a problem for us, right? He needs blood. So that's a problem for me. It's a problem for Becca. And me and Mike had, at that point, started conversating about what we were going to do, right? And at that point, you have to make a decision. And you have to live with that decision, right? So at that point, it was, are we going to try to get blood from the hospital? Or are we going to risk it for the biscuit and send him with an aircraft that didn't have blood product? And that's a decision that you have to make, whether it goes right or wrong, right? So after about 10 minutes of deliberation between me and Mike and a handful of phone calls, we decided to go get blood from the hospital. 25 minutes later, he had blood products administered by hospital staff. The hospital agreed. So there's this thing called EMTALA. They're dicks, but it's basically the authoritative body over the hospital that states that if a patient arrives in the doors of a hospital, that is your patient until another provider takes care of that patient or takes responsibility for that patient. So the second we walked in the back doors of this hospital, that doctor had two options. He could say, "Frick y'all, it's my patient now," or we'll deal with consequences later on if they're partying. Lucky for us, we had a doctor that was willing to deal with the consequences later. Because if he would have leaned on the lawful side of EMTALA, at that point, Mr. Calvin would have sat in this hospital over here for probably about another hour and a half before he could have got shipped out, because then that doctor has to call another doctor. They have to do scans. They have to get permission to send him somewhere, right? So that's where the most appropriate facility, that lingo comes from, right? Because it's not as simple as just going into this hospital and being like, "Hey man, here's your patient. See you in 15 when the flight crew gets here," because that's not what happens, right? So be mindful of that. At 10:31, the aircraft was on the ground, and we got back to the hospital, or got back to the airport. So the entirety of this call at this point has lasted just over an hour and 4 minutes. That's a long time, right? You got to be mindful of this living in this town or in this area, is that there's going to be a delay in extended care or definitive care for these patients. So when you're treating trauma patients, when you're treating high-risk medical patients, just be mindful that there is going to be a pretty significant delay. But again, that doesn't have to be the end-all be-all. If you take the appropriate steps, provide the appropriate treatment, these people can come back home. right? So our little timeline here, this call started in 1918. So when you get paged out to a GSW, you're going to be told to stage for PD, right? Calvin has a fire department pager at his house due to his father being a part of the volunteer fire service in town. Unfortunately, with dispatch, sometimes we get secondhand info. There's a lot going on. When Smith walked into his house 1 minute after Smith was dispatched, they hadn't even paged us out to this call yet. Calvin, when Smith got there, is when they paged us. But when they paged us, they didn't tell us, sheriff's on scene is safe. They told us to stage and wait for the sheriff's department to clear us. As I was driving down the road, I was like, well, it says it's an accidental gunshot to the abdomen. It should be fine. Because I didn't know it was him. I didn't know it was him until I walked inside the house and made eye contact with him. Nobody told us. I had no pre-warning. I was the first one in the house outside of the sheriff's department, and that's when I figured out it was him, right? So there was a delay in us getting there due to some unforeseen circumstances. But we got on scene at 9:27. 7 minutes later, he was decompressed and back stabilized. That's how quick that happened. But you see the timeline of this call. It was a very long process. So keep that in mind when you're dealing with these patients. That was the last set of vitals we got on him before we handed him off to the flight crew. What does that look like? That looks like a patient that don't even have anything wrong with it, right? Like those vital signs are better than probably most of the people sitting in this class. But we went through all the processes of making sure he was stable, right? We did the decompression, we gave him the blood, we gave him the calcium, we made sure he stayed warm, right? Treating your patients appropriately can really go a long ways. That's why Calvin is a perfect testament to this. When you finish this class, it is not a level of your EMT basic licensure is only a licensure. It's not a level of knowledge. You can go out and find the knowledge. You can go out. Calvin's taking critical care paramedic classes just for funsies and pass them. I'm not even a critical care medic, neither is Becca or Hannah, right? But he did it just for fun and passed it because he wanted the knowledge. Go out, find the knowledge, treat these people appropriately, and bring them back home. Especially because this is a friend of ours, right? So that makes it even more critical that we do all the right things and make all the right decisions, because me and Becca talked about it 100 times. If he doesn't come back home, we're not standing here today. I would have walked away from this and I would have never come back. I've seen hundreds of dead people at this point. Whatever. I don't really care. I don't go home and have nightmares from it. I go home and sleep just fine with my 2 little dogs in bed. Right? It's part of the job. That's just me. But if he doesn't come back home, I'll walk away from this. I go work in mine and I never step foot in an ambulance again. You have to live with all the decisions you make in the back of an ambulance, whether they're good or bad. So go out and find the knowledge and treat these patients appropriately. So, again, I said he was a close friend of ours. He was a close friend of everybody involved in the situation. Smith was there. Officer Jenkins, if you don't know him, he was there. Me, Becca, 80, CJ was there, as well as Mike, right? And if you don't know, I'm sure Mike's wife will let you know, he was running 120 miles an hour through downtown trying to get down there. So, scared the piss out of her. Everybody was there. He was a friend, so that makes the treatments, the situation a lot more stressful. Again, it's more stressful because he knows what's going on with him. Most of our patients don't, and they can't tell you what's going on, so you've got to find it. When he's a friend and he knows what's going on,
it just makes it hard because you feel bad for him, right? Because he knows. At some point, he started naming all phone numbers and people for us to call. And we're like, no, they say, you're going to say here. You ain't going to know goddamn where. But he knew that he was going downhill. And that makes the call a lot harder too, right? So capabilities of the local ER, again, they're very limited in their capabilities. He doesn't need to be here. An extended ETA to a surgeon. So from the time that the gunshot initially happened, around 9:15 that morning, I think by the time that he actually made it to a surgeon, it was probably around 11:30, 11:45. Right? That's 2.5 hours from the time of the initial injury to the time that he saw a surgeon, which is what he needs. So the miscommunication on the infill blood products, that made things a little bit more complicated, and decisions had to be made based off of that. Right or wrong, you got to make the decisions and stand by, right? Communication, we made a lot of phone calls to this ER just to make sure that he wasn't going to have to stay here, that we could walk in, get blood, leave, because he did not need to spend an extended amount of time in this ER. The recognition of respiratory compromise post-sedation. Again, just making sure you're paying attention to your patients. That's why every time you give a medication, you check vitals before, you check vitals after. You need to pay attention to what you're doing to your patients and recognize when something's not going the way it's supposed to. So, if, remember, yeah. So Mr. Calvin's going to show you his wound.
Oh, I am?
Yeah.
Yes. Can't believe you guys make me do this. It looks stupid. That's the entrance wound. These are 2 drain holes. That's my surgery scar. That's another drain hole. And this back here is the exit hole.
So this started up here and come out right here. How much stuff can he hit right there? A whole lot, right? So let me see my scar. This is Becca's scar.
That's my needle decompression scar. Where they put the chest tube too.
So do you see how high this is up in his armpit, right? So when he started showing signs of that tension pneumo, that's where we stick it. A good way that we do it is I pull his arm up above his head, I stick my hand up in his armpit. Where that pinky falls, that could goes right in that area. Find a rib close to it, and goes right there in that area, right? Did you see how low that gunshot is, right? It's right here. Why is his lung affected? It's ribs, fragments, right? There's no telling where that bullet goes or where pieces of the bullet. I mean, the bullet's right there, but you got to keep all of that in mind, right? Because when it hits ribs, it shatters, it breaks apart, bones go flying, bullet goes flying, right? I think, and honestly, I thought about this a million times. I think that he was in like an inhalation phase when it happened because it dropped his lung down low enough to penetrate some of those things. Because if he hits his diaphragm, now we're fighting a whole other battle, right? So just keep that in mind. Please take this class serious. This is a testament of everything that we can do pre-hospitally, right? This is a testament of everything we can do pre-hospital. We did everything right that day, right? I'll pat Mike on his back. I'll pat Beck on her back. Smith on his back, right? Everybody worked together phenomenally. From the sheriff's department getting there to us getting there to the hospital. The only people that pissed me off was the goddamn flight company. I digress. But everybody did great. People do not have to die in these rural communities just based off of their injuries and illnesses. Treat your patients appropriately and bring them back home. Because I promise you, The ones that you lose like this will drive you away from this. I've done it 100, I've ran 100 gangbanger shots in the city of Atlanta and hadn't thought twice about him since the day I dropped him off. But if he dies, I'll walk away from it and never look back. Do not let your poor decisions or your poor knowledge be the reason why somebody didn't come back home. Because everybody did great that day. He got extremely lucky from the hospital staff aspect. Everything went the way it was supposed to outside of the flight company. But everything went the way it was supposed to. He was treated appropriately. We hit all the avenues of what needed to be done, and now he's back at work, which I'm sure he loves us for. And you know, he's able to stand up in front of us, help us do class, and you know, he's able to be here to talk about it. Obviously, we're not gonna ask him 8,000 questions about how he felt in the situation, because that's not what we do. But this is a testament of everything that hard work and knowledge goes into. Do not stop learning in this class, because I'm telling you, one day somebody's gonna die on you and you'll think about it for the rest of your life. It's just part of it. So. Any questions? Yeah, I know, kind of intense, but it has to be, because people die and it sucks. And I don't want you to go home and have a rough time because somebody died. Claire, you got something, sir?
Beer Smith.
You. Oh no, Smith did great. Smith's a gangster.
That's a gangster.
So I kept y'all long enough. I appreciate y'all. Y'all be safe. We'll see y'all Saturday. We have class Saturday.
I know we're a little late, but like every day, right? Help tear down. Don't forget one of these. You gotta complete something before you leave. So I'll be at bedtime.
Hey, Chad, why don't we, how do you